Okay. All right. Let's see if I can share my screen.
Mm-hmm.
All right. Are you guys able to see that okay?
Okay.
Yeah.
All right. Well, and welcome. Thank you all for coming today. As Maria was kind enough to say, my name is Jenifer Mc Gowan. I'm from Louisville, Kentucky in the States, like Kentucky Fried Chicken. And I'm an emergency medicine doctor. And I also have an interest in wilderness medicine, or the practice of medicine outside the hospital environment. So I find this patient population very interesting and appreciate you guys coming to chat with me today. I have no disclosures related to this lecture. Oops, I'm trying to minimize my screen here, sorry. I have no disclosures related to the lecture. And with that, we will get started. So we're going to talk about several different parts of hypothermia. We're going to talk about the body's ability to compensate or how to thermoregulate. We're going to talk through the different stages of hypothermia. And we're going to discuss the things that predispose some people to being hypothermic, as well as the pathophysiology behind it, the diagnosis and the management of these patients. If at any point you have questions, just please feel free to stop and ask. Today, we're going to start with talking about Anna, and we're going to come back and reference Anna several times throughout this case. And this is a true story that some of you may have heard before. It's fairly well known. So Anna was a 28-year-old female. She was an orthopedic surgery resident doing her residency in Norway. She was skiing after work in 1999 with her friends. She was a very experienced skier and had skied throughout multiple times, but this time she lost control and fell into a partially frozen stream. Unfortunately, the force that she hit the stream caused her to break through the top layer of ice for her head and her torso to be submerged underwater. She was able to find an air pocket under the ice and was able to breathe and for a period of time gesture to her friends to let them know she was okay, but she could not get out. She had two friends with her. For about 5 minutes, they attempted to free her, but they were unsuccessful. After 7 minutes, they phoned for an ambulance or a helicopter to come and assist with her rescue and to get her out. It took some time to get to her. For the first 40 minutes, Anna was conscious, could gesture and sometimes somewhat respond, but she was submerged in the ice-cold water. After 40 minutes, Anna went into cardiac arrest. So our first question, as this is a lecture on hypothermia, is what happened to Anna? And for this, we're going to go back to our early days of biology and talk about the 4 ways that our body can gain and lose heat. And this is important to keep in mind because these are the things that we're going to use to our advantage later in the lecture or during your hyperthermia lecture when we talk about how to warm or cool a patient. Those 4 methods are evaporation, radiation, convection, and conduction. We're going to talk about each of them in the following slides. So there's 4 main mechanisms that the body loses heat from the skin. The first one that's the largest percentage of our body's heat loss is going to be radiation. And this is when our body is emitting heat in the form of electromagnetic waves or infrared rays to the environment. And again, that's about 60% of our heat loss. And when I was a kid, my mom always told me I needed to wear a hat in the winter so I didn't get cold. And that's to try to stop this radiation heat loss. That's why we help wear clothing to insulate us. It helps prevent this heat loss. There's also conduction, which is when our body is in direct contact with something that's in a cool environment, or that's going to be air. So again, anything to insulate to keep that exchange from occurring, or a contact with a surface. If you've slept on the hard ground outside, you might know this is why we need to use a sleeping pad to try to keep us off the cold ground to avoid that conductive heat loss. Usually this is only about 3% of our typical heat loss, but in special circumstances, such as being submerged in water that's very cold, water is a very effective conductor of heat. And therefore you can lose 30 times, or you can lose heat at a rate of 30 times more efficiently than with exposure to the air. So that sounds familiar from Anna's case. There's also convection, which is kind of similar, and some people get confused with conduction. But this is basically when warm or cool air is blowing over the body, and that breeze, for example, is causing the loss of heat. We see this most commonly with wind chill, and this is also why we use fanning in a hyperthermic patient to try to help cool them. And finally, we have evaporation, which is the primary way that our body cools itself in a normal environment. Sweating is a very common method that I'm sure all of you have experienced before, and this is very efficient for us to lose heat. But even if we're not sweating, every time we breathe, our humidified air in our lungs is being exchanged with the environment and losing water to the environment. We call this insensible water loss because we don't really appreciate it, but it's occurring at all times. And usually evaporation is going to be about 22% of our heat loss. So going back to talk about Anna a little more, just to review, the mechanism of heat loss that Anna primarily experienced in this case was going to be conductive heat loss due to her submersion in the water. Again, water's conducting that heat 30 times more efficiently than air, and it's very rapid. It does not take long in ice water for someone to become unconscious, sometimes as little as 15 to 20 minutes. Now, I think you guys have seen these slides in a previous lecture on hyperthermia, I'm told, but we're going to touch on these briefly just as a review. So when the body starts to perceive cold, it's trying to warm itself. Your hypothalamus is going to be that regulatory control of the brain. And when it feels this cooling, it's going to activate your nervous system, and the arterioles in your skin, especially on the periphery, are all going to vasoconstrict to shunt all of that blood into the core to try to maintain a normal body temperature for your core body organs, such as your heart, your lungs, your liver, those things, because it considers your extremities to be somewhat expendable. You can live without an arm, but you can't live without your vital organs. At the same time, your adrenal glands are going to start increasing some hormones, epinephrine, norepinephrine, as well as some increasing thyroxine. And this is going to increase your metabolic rate to try to help warm your body as well. That isn't going to be as quick as the vasoconstriction. That's going to take more time. The other thing your body can do immediately to try to warm itself is to make you shiver. And that's about the only way our body can immediately generate heat. As the muscles contract, the heat's going to be produced up to 5 times the normal amount. However, this comes with a very high caloric requirement. It takes a lot of energy and fuel for the body to maintain shivering. A lot of animals, including humans, have something called piloerection, where the hairs on the periphery stand up and cause you essentially to have goosebumps, as we say. This works well if you have a full coat of hair, but we don't. Our extremity hair is fairly limited. So this really doesn't do a lot for us, although this is why evolutionary reasons that we get goosebumps when we get cold. So today, again, we're going to talk about accidental hypothermia, which is the unintentional decrease in your core body temperature below 35 degrees. It can come, we're going to mostly focus today on environmental exposures, but of note, sometimes you can have a secondary hypothermia in which you become ill from a medical condition, and then due to the body's ability to not compensate any further, also become hypothermic. Either way, it's still considered accidental. So going back to Anna, it's now been 80 minutes of being submerged in this icy stream, and she was finally freed by the rescuers. She was in cardiopulmonary arrest. Her pupils were fixed and dilated, and her heart was in asystole. The reports say her skin was white and waxy, and she looked like a corpse. Her temperature at that time was 13.7 degrees Celsius. So what stage of hypothermia was Anna in at this time, and how severe was it to have a core temperature of 13.7? I don't ask you to remember all of the things on these next few slides. This is just an overview to try to help you grasp what level is which. So for mild hypothermia, you're going to see a core temperature from 32 to 35 degrees. If someone's temperature is 36, they're not technically hypothermic. We just call that cold stressed. So with mild hypothermia, these patients are profusely shivering. That's what I always tell my trainees to look for. These people are shivering and shivering. If you can get them out of the environment and warm them, they usually do fairly well. They're still able to help compensate and rewarm themselves. However, once someone progresses to moderate hypothermia with a temperature of 28 to 32 Celsius, they're losing their ability to shiver. They no longer can warm themselves, and their mental status is declining. These people will progress unless you remove them and actively try to intervene to warm these patients. And then finally, when someone becomes severely hypothermic with a core temperature less than 28, at this stage, they're generally going to be unconscious. They can't shiver. They cannot generate their body heat, and they're going to suffer cardiac arrest and further heat loss if you don't intervene to warm them. And again, just for completeness sake, for reference, the point of this is just to look and see kind of how things progress throughout the stages. So if you're mildly hypothermic, initially you're shivering, you might need some extra fuel to help warm, to sustain your calories, to warm yourself. You might be a little uncoordinated, but even as that progresses on from 35 to 33, you'll see that these patients rather rapidly become ataxic, apathetic, and are struggling more and more with each degree of temperature loss. And as that progresses on to moderate hypothermia, again, big picture, not the fine details here, but you can see as that number decreases, they become more stuporous, they've lost their ability to shiver, and you start seeing arrhythmias of the heart, diminished blood pressure, decreased cardiac output, to the point that these people become unconscious, bradycardic, and their respiratory rate diminishes as well. Finally, once you're severely hypothermic, once you hit 28 degrees Celsius, you're very prone to arrhythmias, which we'll talk about in much more detail on later slides. Reflexes are lost, pulses are very low, and at 19 degrees, we find that these patients are in asystole with a flat EEG. These people are considered profoundly hypothermic, which is kind of a subcategory of severe hypothermia. And again, Anna's core temperature was 13.7. Going back, at 19, we expect asystole and a flat EEG, and she was 13.7. So we've kind of talked about how our body thermoregulates, and you can imagine anything that interferes with this thermoregulation is going to make heat loss worse. So we're going to touch on the other parts of this triangle. And first, we're going to talk about in ways in which our bodies had increased heat loss. So under typical weather conditions, as we mentioned before, evaporation, including your respirations, is going to be about 20 to 30% of heat loss. Conduction and convection is going to add up to about 15%, but radiation is going to be the main way in which our body loses heat. That's going to be 55 to 65%. So we worry about the temperature in the air as it has a very large influence on how fast our body loses heat. The colder it is, the faster we will lose heat due to the large temperature gradient between the two. Other things that we worry about is if there's wind, that convective heat loss moving over the body, which will speed up the heat loss as well. In contact with the wind or the outside environment is going to be reduced by the clothing primarily. So what type of clothing someone is wearing, whether it's windproof or waterproof, and how much they're wearing, if they have on a good insulating layer versus just a light shell jacket. Other things we think about is exposure. It makes sense. If you were out in colder temperature for a long period of time, you're going to lose heat more rapidly than if it's a short period of time or a warmer temperature. Sometimes we do things to patients or patients do things to themselves that'll cause them to lose more heat. Certain medications are known to expedite heat loss. Using alcohol is going to make it harder for your body to regulate. You might hear of patients that had been drinking heavily outside and were unaware how cold it was that were found unresponsive. Usually our IV fluids are stored at room temperature. And if you take a patient to the operating room, that tends to be a very cold environment. So those are ways that we can influence the patient or they can influence their own to lose more heat. Any kind of skin condition that interferes with your body's ability to heat exchange, such as psoriasis or burns, is going to make it easier for the body to lose heat. And then also acclimatization. After you've been repeatedly exposed to a cold stimulus, you get more used to that. So one example is fishermen in very cold waters that are constantly submerging their hands in water eventually become more tolerant, and they are less prone to cold injury to their hands just because their body is used to it now. The other way that our thermoregulation can be impaired is going to be through decreased heat production, or no longer making enough heat to keep our body warm. The young and the old are going to be less able to compensate for any kind of heat stress or cold stressors. They just cannot thermoregulate as efficiently. If you don't have adequate fuel, if you've not been eating and consuming enough calories, that's a very high energy requirement to sustain heat generation. Shivering is very taxing metabolically on the body. Those who have an endocrinologic insufficiency, such as those with hypothyroidism or adrenal insufficiency, might not be able to produce heat as effectively as others. And then those who have neuromuscular conditions that might make it difficult for them to shiver, such as ALS, muscular dystrophy, myasthenia gravis, all of those people might not be able to generate enough heat to keep themselves warm. Again, our bodies are very effective at cooling. We have 4 ways that we can lose heat. We can sweat. There's a number of different mechanisms, but we really only have one way to generate heat, and that's shivering in the acute setting. The others, hypothalamic regulation, metabolic, increasing your thyroid hormones and epinephrine production, those take longer. They're not as quick as shivering. And if any one of those fail, you're going to continue to lose heat at a more rapid rate. Our body tries to conserve our heat loss, again, with the vasoconstriction of the skin, primarily on the extremities. But as we run out of calories, as our body's energy reserves become depleted, that vasoconstriction eventually will fail, and even more heat is going to be lost from that sudden vasodilation. So there's multiple organ systems affected, as you can imagine: neurologic, cardiovascular, your respiratory system, renal, and your coagulation cascade, which we will touch on each of these briefly in the following slides. So from a neurologic perspective, we see a decrease in cerebral metabolism as the body is cooled. For every 1 degree of cooling of the body, we see about a 6 to 10% decrease in the cerebral metabolism, which is somewhat protective and partially why some of these patients have good neurologic outcomes. With this, we also see our patients having impaired memory and judgment, and their motor skills quickly diminish, starting with some clumsiness and loss of fine motor skills, progressing to the extreme end, they have a complete loss of reflexes. We also see some risk-taking behaviors, poor judgment. And one reason this is hypothesized from, as well as from the neurologic perspective, is you might have heard stories of somebody who became very cold, but then was found undressed in the snow and had taken all of their clothing off. And it's thought that once they have lost their ability to cope with the cold temperature and their body can no longer vasoconstrict, like we mentioned on the last slide, when that fails, there's a sudden vasodilation of the extremities. The blood rushes back to the extremities, which causes this paroxysmal, the body gets confused and feels now, oh my gosh, I'm very hot and overheated due to the sudden rush of warm blood. Hence why some of these people might be found having removed their clothing or have jumped in a river, something that seems to make no sense for a patient that was hypothermic. From a cardiovascular perspective, initially we see tachycardia as the body is shivering and trying to maintain body heat. But as those temperatures drop and the warming mechanisms fail, it's going to progress to a bradycardia. We see a prolongation of the cardiac cycle. The entire QRS interval on the EKG will widen. Then you'll see delays between P waves, the QRS, and T waves. We also, similar to the cerebral perfusion, will see a linear decrease in your blood pressure and your cardiac output as that temperature again continues to drop. During hypothermia, essentially everything slows down. Similarly, in the initial mild hypothermic stages, as the body's shivering profusely, you might see somebody with an elevated respiratory rate. But again, as that temperature drops, we're going to see a decrease of their respiratory drive and a lower respiratory rate. Once these patients become moderate to severely hypothermic, we start to see a ventilation and perfusion mismatch. There's several things that contribute to this. For one, as the chest wall muscles stiffen, it becomes harder to ventilate. And then as there's decreased perfusion and decreased blood pressure, you get diminished perfusion to your lungs as well. So there can be those and several other factors that can lead to essentially a hypoxia in these patients. From the VQ mismatch, you can see atelectasis, bronchuria, and even pulmonary edema develop on the X-ray. These patients have a decreased respiratory minute volume. They also have decreased tissue perfusion from their decreased cardiac output that can show up as well as oxygenation changes. And then again, as the body's trying to shivering and rewarm, that's a very energy consuming process, and that can also increase your oxygen consumption, which can lead to hypoxia as well. Talking about the kidneys, our renal effects are seen mostly from the peripheral vasoconstriction that we've mentioned several times. As the peripheries vasoconstrict, it shunts all of that blood to the core. Your kidneys recognize that as a volume overload of the central organs. And its response to that, as it would in any other situation, would be to diurese. So we call this a cold diuresis. It's not a true hypervolemic state, but it's a perception of that due to shunting. So you should keep this in mind because of this, all hypothermic patients are going to be very dehydrated generally because they've had this cold diuresis, increased urine output, all secondary to the shunting. As you rewarm them and peripheral vasodilation occurs, and blood pressure is going to, which we'll talk about in more slides, but the blood pressure will drop and they're going to be very dehydrated. You'll need to replenish their fluid reserves. And then touching on coagulation, many of you probably are aware that your clotting factors are impaired by cold temperatures. They don't work as well. We see this sometimes in trauma patients where we talk about trying to avoid hypothermia. When blood tests are performed in a lab, the labs are performed at your normal body temperature of 37 degrees Celsius. So if you have a hypothermic patient with a temperature of 28, you've drawn that blood and taken it to the lab, but it essentially gets warmed and while the sample is being analyzed. So the results might appear normal. However, the patient might actually be coagulopathic despite these normal lab values because they're just not working. The factors are all there, but they're not working effectively at a cold temperature, if that makes sense. And then we're going to talk through a few things about your hypothermic patient, what their vital signs will look like, what their exam might show, what might we see on an ECG, laboratory evaluation, and if imaging is indicated. So your vital signs, as we've mentioned, talking about cardiac output, you're going to have a decrease in your blood pressure as your temperature and your cardiac output both decrease. Your heart rate is also going to decrease as your temperature decreases. And this is very important because if you're performing a pulse check to see if someone is in cardiac arrest, the usual 5 to 10 seconds is not going to be sufficient. You need to do a prolonged pulse check for 10 to 20 seconds to make sure that this person is truly without a pulse and not just bradycardic with a low heart rate that might take longer to detect. Again, as we'd mentioned, originally the respiratory rate will increase, but then once they're moderately hypothermic, it's going to decrease. And if you're able, the gold standard of temperature measurement is going to be continuous core temperature measurement, which we'll talk about more late in a few slides. So again, the continuous core temperature monitoring is gold standard. The most common methods are going to be either a continuous rectal probe or a temperature sensing urinary catheter. There are more invasive methods that can be used, such as endovascular probes or esophageal probes. The problem with those is endovascular probes often require central line placement or an arterial pulmonary artery catheters even. And esophageal temperature monitoring requires intubation to be performed, whereas a rectal probe or a temperature sensing urinary catheter allow for continuous measurements with less invasive means. The important thing on these is all other forms are considered to be not very accurate. any kind of axillary temperature, tympanic, oral temperatures really should just be avoided in these patients, as they either don't register or are not accurate below 35 degrees. They can be used to rule out hypothermia. If you have a shivering patient whose oral temperature is 36, that's probably okay. But otherwise, if you're suspecting mild hypothermia or below, you need to get a core temperature measurement. EKGs or ECGs in hypothermic patients have some very interesting findings. Again, we've mentioned several times now that you see bradycardia. Usually we start seeing this in the moderate stage of hypothermia, again, from 28 to 32 degrees Celsius. You then start to see prolongation of your intervals as you have slowed conduction through your potassium channels. Another very interesting finding is going to be your Osborne waves on your EKG, which is elevation of the J point that we'll look at in detail on the next slides. And then as hypothermia progresses, the most feared complication is going to be your ventricular arrhythmias, leading to cardiac arrest. And these ultimately will progress to asystole if the patient's temperature continues to drop. So these are some examples of Osborne waves or J waves. Both of these are the same, just one's a little more close up. And what these are, as you can see where the arrows are, you get this upward deflection at the J point, which is at the junction of the QRS and the ST segment there. You see it mostly in the precordial or anterior leads. They can be pretty pronounced, or sometimes they can be a little more subtle, like that one can be a little harder to see. These are benign. There's nothing to treat, and they completely resolve with warming of the patient. They're not isolated to hypothermia. You can see some sometimes with some intracranial processes, but in the setting of a cold patient, they're essentially pathognomonic for hypothermia. And again, this is another picture of the J point elevation of the Osborne waves. Interestingly, the height of the J point elevation roughly correlates with the degree of hypothermia. And if you have a higher elevation, generally the core temperature is lower. So you can see on this EKG, it appears it is more bradycardic, has more of a prolongation of the cardiac cycle, and the J point elevation is more pronounced when compared to the previous slide. So this patient appears to be more hypothermic than the patient on the EKG we looked at on the last slide. One other thing to keep in mind is shivering can cause a rhythmic irregularity on the EKG that looks a lot like ventricular tachycardia. So that's something to keep in mind. But remember, we see shivering with mild hypothermia, but moderate and below patients are no longer shivering. We start to see arrhythmias at moderate and severe hypothermia. So you really won't see a shivering patient that's also in VTAC. So look closely at this, and you can see there's still QRS complexes that are buried underneath this rhythmic jerking from the shivering. Going back to Anna now. After 80 minutes of extrication, she was flown by helicopter to a nearby large university hospital. There were a dozen medical staff involved in the operating room. I think it was 9 hours in total. They used very aggressive measures, including starting Anna on cardiopulmonary bypass to try to rewarm her. 3 hours after she had been pulled from the icy stream, about 4.5 hours after she had initially been submerged, her heart began to show the first signs of electrical activity again. So, should we get imaging in our hypothermic patients? We've mentioned now multiple times that these hypothermic patients are at risk for arrhythmias. We're going to talk more about that later, but for now, just keep in mind that movement should be minimized in these patients. Most of these patients don't need imaging unless by the history there was a significant trauma that led to the hypothermia, such as like an avalanche occurring or something like that. However, most hypothermic patients who have an altered mental status, they don't need a head CT. Their mental status changes are going to improve with warming. The hypothermia should take priority. They'd be too unstable for any kind of intervention anyway. You could consider getting a chest x-ray on these patients, preferably at the bedside, to look for pulmonary edema. Some people that are very into point-of-care ultrasound might look with a lung ultrasound to see what their lungs look like. but most any other imaging likely can be deferred until the patient's rewarm and has stabilized some. So are there specific exam findings for hypothermia? Other than the core temperature, which is pretty pathognomonic, there are a few things we'll note. So the patient's mental status is going to get progressively lower, and their GCS, Glasgow Coma Scale, is going to decrease as well as the hypothermia progresses. You're going to see a lot of musculoskeletal rigidity with motor impairment, especially in the early stages. And as it progresses, you'll see diminishing reflexes until eventually they have no voluntary movement and no reflexes at all. Some things to consider, especially if it's a severely hypothermic patient that you're having to assist with ventilations. The rigidity of the patient's chest wall can make ventilation difficult. It's a very stiff chest. These patients can be very hard to bag for oxygenation. And then if this patient needs intubation, they can have such pronounced jaw rigidity that intubation is very difficult or impossible. It almost mimics a rigor mortis. It's very challenging to open the mouth to get a blade into their mouth to perform an intubation. I've had this happen before myself on these patients, and it's quite challenging to get them intubated. And again, as the cardiac output and blood pressure decrease, as they become more bradycardic, it can be very challenging to palpate a pulse on these patients. So really take time, do a prolonged pulse check. Some things that are notable for laboratory evaluation in these patients. So as the body performs cold diuresis, shunts all the blood to the core, and urinates out all of the excess volume, you're going to get a masking of your anemia, essentially from hemoconcentration. They say it's about 2% increase of your hematocrit for every 1 degree drop in your core body temperature. You'll see some sequestration of your white blood cells, which can make your lab values a bit misleading. There's no safe predictors for survival with serum electrolytes, but if you have a potassium greater than 12 at any point during the cardiac arrest, that's considered to be non-compatible with life, and that's an indication to cease resuscitative efforts immediately. So on a prolonged cardiac arrest, about every 1 hour, I will get a repeat potassium level and see, because if it gets to 12, even if the patient is still cold, we cease our efforts at that time. And as expected, you'd see some elevation of your BUN and creatinine due to the cold diuresis and the dehydrated state. Otherwise, most of the other lab values would be as you'd expect and not significantly altered. So we're going to talk a bit about pre-hospital care for the hypothermic patient, because most patients are not found profoundly hypothermic in a hospital setting. They're usually found in an outside environment and then transported to the hospital. So this is important because these patients, as the illustration shows, are very fragile. So we talk about packaging, or getting our patient ready to transport these hypothermic patients out in the field. It's very important to keep the patient horizontal. You don't want to allow this patient to sit up or to stand up. These position changes can cause the blood pressure to drop quite significantly. It can also lead to a sudden dysrhythmia and a cardiac arrest. We call this a rescue collapse, and it's a very well-studied phenomenon in which these horizontal to then vertical position changes lead to a complete hemodynamic collapse and cardiac arrest. You want to stabilize any concurrent injuries with a bandage or splint as you're able, and you want to dry off the patient as much as possible. Wearing wet clothing or being soaking wet is not going to help with further heat losses, again, because water is such a good conductor of heat. You want to wrap them up and, as we say, package them to keep them from getting colder. So if possible, in the patient's clothing are dry, you want to leave that on the patient. However, if the clothes are wet, if you're able to and have something dry you can put over them, you would then remove them, again, to reduce that water loss or the heat loss through the conduction. Best you can, you want to add insulating layers around the patient. And then your outer layer, ideally, is going to be windproof and waterproof, especially if it's raining or snowing. You want to try to insulate them from the elements as best you can. Tarps just like the construction kind of tarps are very useful that are both windproof and waterproof. It doesn't have to be actual clothing. Anything you have can work for this. You want to provide insulation between the patient and the ground. So again, putting them on like a sleeping pad or similar if they're going to be laying on the ground until rescue can come, to try to break up that conductive heat loss. You can use heat packs, but do it cautiously. You don't want to put them directly on the patient's skin. You want to be very careful not to cause burns on the patient, because many of these patients are going to have a decreased level of consciousness or going to be having some peripheral nerve problems due to the cold, and therefore they won't perceive how hot something might be. This is an example of what we're talking about, and you can see over their initial layer of clothing, you could apply a heat pack, some insulating layers, maybe that's blankets, a sleeping pad, sleeping bag, whatever you have. And then an outer layer that's going to be windproof and waterproof, some kind of plastic-like covering. And then you also want to make sure you don't have them lying on the cold ground if at all possible. So we've talked about arrhythmias a little bit, and we're going to touch on that more now. These patients' myocardium is very irritable, and it's very prone to arrhythmias. Ventricular fibrillation is unfortunately the most common, but you'll see ventricular tachycardia as well. And this really shows up when the core temperature falls below 30 degrees Celsius, which is the low end of moderate hypothermia, approaching severe. Any position changes in the patient, sitting or standing them up, any jostling, accidentally hitting the bed, moving the patient from a stretcher to the bed, those are all very high-risk activities in these patients and are likely to induce an arrhythmia if the core temperature is below 30. You want to be very careful with intubating these patients or placing a central venous catheter in the subclavian or interjugular vein, because the proximity of the endotracheal tube or the catheter to the heart can cause direct stimulation, irritability, and then ventricular fibrillation. So these patients need cardiopulmonary resuscitation, and it can be quite prolonged. We'll talk about it later, but they must be warmed fully before resuscitative efforts can be stopped. There are a few exceptions. If you have an obvious do not resuscitate order and that can be verified, you would not resuscitate. If they have obviously lethal injuries, if the patient has been decapitated, you don't need to try to resuscitate them. In some instances, the patient might actually be frozen solid to the point where chest compressions are impossible. And that's going to be considered futile care as well, and you would not initiate CPR. Again, they can have a very faint, prolonged pulse, and you really need to do a long pulse check to see. So if they have any signs of life are present, even a slow pulse, you do not do CPR on them. If it's going to endanger your rescuers and lead to significant evacuation delays that would harm the rescuers, that would be an instance to say we can't do this. And then again, if you have laboratory evaluation capabilities, a potassium greater than 12 would also be an indication to not resuscitate further. So keeping in mind, you'll hear me say this several times, you want to handle those patients very gently to avoid arrhythmias when you're trying to resuscitate them. You're going to use warmed IV fluids if possible, 40 to 42 degrees Celsius. If you have the ability to have like an inline fluid warmer in the hospital, that's great. A lot of places don't, and you actually can just put the fluids in a microwave and cautiously microwave them until they feel warm, but not burning hot that would cause burns. You can use vasopressors in refractory hypotension, but a lot of the times medications are not very effective when the core temperature is below 30 degrees. So you can consider them, but they might not work. Again, very careful pulse checks for a prolonged time of 10 to 20 seconds, because they're going to be bradycardic. And then when you're doing CPR, you're going to continue to perform your chest compressions at the normal rate of 30 to 2. But if the core temperature is less than 30, you can consider just performing CPR continuously without checking for pulses until the core temperature has raised to 30 degrees. We'll talk about that more in a bit. But just know you don't have to do pulse checks, or you could space them out to longer intervals if the core temperature is that low. If you're using an AED or a monitor defibrillator, there's some mixed literature. Some say do no more than 3 shocks for ventricular fibrillation or tachycardia if the patient's temperature is less than 30. Other sources say only 1 shock, and if they're not responsive, then just continue warming them until the temperature is above that. Mixed literature, so I would say just no more than 3. You don't need to persistently do pulse checks with defibrillation attempts if the temperature is less than 30, because it's not going to be very effective. You're going to be very conservative with your use of medications on these patients as well. Obviously, if someone is not responsive, we try to not give them any medications by mouth. And then a severely hypothermic patient, they're not going to have very good bioavailability or absorption. So again, we're only going to give medications through an IV or an IO at this time. The medications aren't similar to the defibrillation attempts. The medications just are not going to be as effective at cold temperatures. The vasopressors, similar to a patient with severe acidosis, they just don't work well when a patient is cold and or acidotic. In our hypothermic cardiac arrests, our advanced cardiac life support medications like amiodarone and epinephrine really are only recommended to be given when the core temperature is greater than 30. And that's because these cold temperatures impair your drug metabolism. And the concern is for repeat dosing, it's not going to be cleared from the body that can lead to pretty rapid toxicity. When the temperature then is improved to greater than 30 degrees, from 30 to 35, so mild and moderate hypothermic patients, if they're in cardiac arrest, you only want to do the epinephrine about half as often as you would in a regular cardiac arrest. So instead of 2 to 5 minutes for epinephrine, you would only do it about every 6 to 10. You could also consider halving the dose of your amiodarone to avoid these toxicity effects. Again, they just don't work well when the patients are cold, and there's a high likelihood of toxicity. So they're really just not indicated at all when the core temperature is less than 30. And similarly, only 1 to 3 shocks on a defibrillator if that temperature is that low. There's something called an after-drop phenomenon that you'll see in most all of your hypothermic patients as you try to rewarm them. What happens is as the patient starts to rewarm, the core temperature paroxysmally will actually decrease, and you'll feel like you're like, oh no, what's happening? I was making good progress. And what's happened is the vasodilation of the extremities that are being warmed will then cause return of very cold blood from the extremities to the core, causing that temperature to drop further from your core temperature measurement. You want to try to rewarm the core of these patients first, so really focus your efforts on the trunk before you try to warm the extremities. And so if I'm warming a hypothermic patient, I'm going to have their extremities out from under the blankets and try to delay the warming of those as best I can. There's many techniques for rewarming. We start with the most benign or easy to do, and we call that passive rewarming techniques. On these patients that are exposed to cold but aren't yet hypothermic, so their temperature is greater than 35 degrees, passive techniques are appropriate. These people, essentially, you're going to take them out of the cold, take off any wet clothing, give them dry clothing, and these people can warm themselves. If you give them high-calorie foods and warm beverages, maybe a warm blanket, they tend to do very well and warm up quite quickly. As we move along to patients that are mildly hypothermic with a core temperature of 32 to 35 Celsius, we're going to focus on active external techniques. We're going to use forced warm air devices. The brand we have here at my hospital is called a bear hugger. There's also things called an Arctic Sun. Any of those kind of forced warming devices works well for these patients. But again, it's all external. You also can do warm humidified oxygen. And then you can also start some warm IV fluids, although arguably that would be internal as well, but we tend to lump it in with the active external. And again, those fluids are going to be about 40 to 42 degrees Celsius. As we start doing active internal techniques, this is going to be more for our moderate to severe hypothermic patients. So the temperature from 32 and below. For these people, they really do need warmed IV fluids. They're going to be dehydrated, and they're going to be very cold. If you have endovascular warming catheters, that is an option. I don't believe they're fairly rare. They're only available in a few places. I believe I heard you guys do not have those there, but keep in mind if they ever appear, that is an option. Hemodialysis is an option, especially in patients that are hyperkalemic and profoundly cold. If you're able to do hemodialysis, that warms patients pretty effectively. There's also techniques of peritoneal and thoracic or pleural lavage, which we'll talk about on the next slide a bit. And then at the most extreme, extracorporeal life support or ECMO would be an option to rapidly rewarm these patients. Anna, in our case, was placed on cardiopulmonary bypass for her warming measures. Now, in the past, there was discussions about bladder and gastric lavage as active internal rewarming techniques. Those of note are no longer recommended due to the high risk of complications. Patients were found to aspirate or have perforation, and it really did not work very effectively to warm them. So those are not recommended anymore. And talking about kind of our most aggressive means of active internal warming measures, peritoneal lavage with just inserting warm fluids into the peritoneum, agitating the patient slowly, and then suctioning them out. It's very invasive, and generally it's going to require a general surgeon to assist because you're essentially doing an exploratory laparotomy to get into them to do this. You can do thoracic lavage with warm fluids. It's invasive, and it can be hard to do your chest compressions while the chest tubes are being placed. When you do this, it requires 4 chest tubes to be placed on both sides, an anterior and posterior placement. So the warm fluids can be infused through the anterior chest tube and then drain out the posterior. Generally, these techniques are only considered in hypothermic cardiac arrests at places where ECMO or ECLS are not available or the patient is deemed to be not a candidate. It's kind of a last-ditch effort. And these resuscitations can take a long time. If you're doing these, they can take 6-8 hours sometimes to fully rewarm the patients, unfortunately. And what are the complications of hypothermia? We've touched on several of these. The cardiac arrhythmias are probably the most feared one because that's going to really complicate the rewarming process if they go into cardiac arrest. Pulmonary edema, it can be very difficult to oxygenate these patients. They can become coagulopathic. Then they can have other complications as you'd expect from the cold exposure, such as frostbite, tissue damage. And then as they've had decreased blood flow and low blood pressures, as those are increased to the extremities, you can develop a compartment syndrome. And then, of course, these patients, unfortunately, the severely hypothermic patients, unfortunately, often can succumb to their hypothermia and die. So going back to Anna, she spent 9 hours in the operating room that night, undergoing aggressive resuscitation before she was transferred to an ICU. Her lungs failed rather quickly, and she required intubation. She spent 35 days on a ventilator. Her kidneys failed as well. She required dialysis. 10 days after her cardiac arrest, Anna woke up. But unfortunately, she was paralyzed from the neck down. She was very angry, and now states she wished her friends had not attempted to revive her and was very unhappy about this. So, touching again on these arrhythmias in hypothermic patients, people suffering from an atrial arrhythmia, often you'll see an atrial arrhythmia with a slow ventricular response, and that's usually harmless. Once the patient is warmed, they usually spontaneously convert to a normal rhythm. You want to avoid any kind of unnecessary treatments or medications and just warm the patient. The ventricular arrhythmias, like we mentioned, ventricular fibrillation is going to be the most common, but we do see ventricular tachycardia as well. Again, a few of these important points I say several times. The medications are not going to be effective at low temperatures. They have a decreased metabolism, and you're going to be at risk for toxicity. If you give them, limit the doses and don't give them if the temperature is below 30 Celsius. And what about pacing in these patients? It's not recommended because there's such a concern for further myocardium irritability that you don't want to pace them because that can unfortunately send the patient right into ventricular fibrillation. So how do you treat these people? since it's so common with the core temperatures less than 30. Again, up to 3 attempts for defibrillation. Some sources say only 1. If the third attempt fails, wait until your core temperature is above 30 degrees before you try again. So 30 is going to be kind of your magic number for medications as well as defibrillations. Don't give multiple doses of medications if the core temperature is that low. And again, once it reaches 30 degrees Celsius, you can double the interval of the medications compared to the normothermic patients. So again, every 6 to 10 instead of every 3 to 5. And then once the temperature reaches 35 degrees, then you can return to normal intervals, normal dosing for your cardiac arrest patients. So what are the factors that predict a poor prognosis in hypothermic patients? Patients that the concern was for a primary asphyxia, then became hypothermic, such as those who have drowned or people who have been buried in an avalanche, have a very poor prognosis. A cardiac arrest that was unwitnessed or with an unknown downtime. Initial presentation in asystole is a worse prognosis, as we don't know how long they've been down, and generally they're very cold with a low core temperature when they are in asystole. Anyone that is alive that has hemodynamic instability is high risk for progression to dysrhythmia and cardiac arrest. And again, anyone that has a hyperkalemia of any sort, but especially if it starts getting very high, has a very poor prognosis. Elevated serum lactate in an acute kidney injury also are poor prognostic indicators. And then the elderly, I would argue the very young as well. So I would say age less than 2 and greater than 75 have a poor prognosis. One thing to remember, if a patient becomes rapidly hypothermic and then arrests, that's a good prognosis. Whereas someone who had a cardiac arrest and then became hypothermic has a very poor prognosis. So your best candidate for aggressive rewarming measures and a good neurologic outcome is going to be patients like Anna, who had a cold water immersion but did not drown, that then became rapidly hypothermic and suffered a cardiac arrest. These patients often have the best clinical outcomes of any hypothermic arrest. So the speed at which they become hypothermic is important. So Anna spent 2.5 months recovering in the ICU. Then she underwent another 4 months of rehabilitation at an inpatient facility. Her neuromuscular function did gradually return, and she suffered no long-term brain damage, which is pretty remarkable. So how do we prevent these hypothermic incidents in the field? You really want to be sure to plan and prevent. You don't want to deal with a hypothermic patient. You want to plan to avoid hypothermia. Make sure patients and yourselves are well insulated. Avoid contact with water. And if you do have wet clothing, change it promptly. Try to avoid prolonged field exposures, because that's going to increase your risk of heat loss. And make sure if you're going to be out in the cold to increase consumption of calorically dense fuel, so your body has opportunities to generate more heat and rewarm yourself. In an urban area, you want to make sure that the heat is on in an indoor temperature if possible. Sometimes this is challenging, and we see cases, unfortunately, with people that do not have heating that become accidentally hypothermic inside their own homes. So programs, if they exist to provide financial assistance to those so they can have heat in their homes, are wonderful. If financial concerns exist, advising people to selectively heat their sleeping quarters so they don't become accidentally hypothermic while asleep. And then those who don't have heat, if places are able to set up temporary warming centers, temporary shelters, that's very much appreciated. You need to be very aware and recognize cold stress or mildly hypothermic patients and start rewarming them aggressively, because that's what's going to save lives. You need to recognize it early and treat it promptly. You do not want your patients to progress to moderate and severe, because that's just a continuous spectrum that can cause a lot of deaths if not recognized. So in summary, a few more slides here. You're going to very carefully handle these patients to avoid inducing any kind of arrhythmia. If the patient is severe or moderately hypothermic, it's going to be best to transport them to a high level of care facility if possible. You want to rapidly rewarm these patients as rapidly as possible until they're normothermic. You want to rewarm that trunk first to prevent afterdrop. And one more time, we're going to limit our use of defibrillation, and we're not going to not use medications in patients whose core temperature is less than 30 degrees. We say patients are not dead until they are warm and dead. These patients, when hypothermic, suffering a cardiac arrest, must be rewarmed until you can call time of death on them. This is a very long, labor-intensive process. You want to avoid cardiac arrest if at all possible. 5 months after her accident, Anna returned to work as a physician, although she did change specialties and became a radiologist. It was 1 year after her accident, she was able to walk again. At that time, this was the lowest recorded core temperature to be resuscitated and survive. There has since been one pediatric patient who was a few tenths of a degrees colder that now holds the record. Anna, to this day, is still working as a radiologist in the hospital that saved her life. And I use her story here to illustrate this is why this topic matters and why I hope you guys take this seriously and try to aggressively treat and resuscitate these patients, because they can have, even after a terrible prognosis, they can have an amazing recovery and do very well. And I use this picture. This is me. Again, one of my areas is in wilderness medicine, and I go every year to Antarctica for a period of time to serve as a physician in Antarctica. And this was one of the pictures from there. You know, and this is an important topic to me because when you're in a cold environment with limited resources, it's really up to you to be able to manage these patients and save them from death. And that might be on your streets outside the hospital in an urban environment. It might be an hour away from a hospital in a more rural area. It might be on a ski trip. But wherever you are, it's important to be able to recognize hypothermia and treat it effectively to save these patients' lives. So thank you all.
Thank you, Jenny. It was very interesting, brilliant lecture, and your style is my favorite style of lecture, with combination clinical case and some explanation. In chat, we have some questions to you. How quickly does the mental state recover after such a stressful situation, and do you use medicine for recovery? Oh, for example, Anna.
So I think we're going to have an opportunity in another month or so to go through some more cases, possibly in another lecture. And I have some that'll illustrate that very point, because the mental status remarkably improves about as quickly as it decreased. So as you warm the patient, they make very rapid improvement of their mental status. And unless they were in cardiac arrest or critically ill intubated, the people that were just largely unresponsive, when you get their core temperature up into the mid 30s, they usually are awake and talking very quickly. It's pretty impressive to watch.
Mm-hmm. And maybe what kind of medicines do you use in period of intensive care, and of course after resuscitation and post-resuscitation period for improve recovery of the brain? Maybe do you have in something specific?
Yeah, there really aren't any specific medications because the neurologic effects come from the cooling, so the return comes from the warming. And as the body cools, it has neuroprotective effects that kind of shelter the brain from the usual insults from the lack of oxygen. So as soon as the core temperature improves, you see pretty impressive mental status improvement. And there's really not any medications that have been shown to help with that. It's just warming and time. I always say these patients require a lot of patience because you just have to be calm and wait for things to improve.
And maybe how often, maybe it's faster or same rate, I mean, development of acute brain edema after resuscitation of especially patient who has a cardiac arrest due to hypothermia.
Mm-hmm.
Do we have differences or not?
Yeah, they tend to develop less cerebral edema than the usual cardiac arrest patients, just because the temperature was so low, it was protective, because the brain required less oxygen and less metabolic demands while it was cold. And because of that, you have less ischemia and therefore less edema. So it's not a perfect correlation, but the faster they got cold and the faster their brain was cooled, typically the less long-term effects, the less edema, the less long-lasting neurologic impairment that you will see.
Thank you. And how much time is spent on average for resuscitation of patient with severe hypothermia? How long it could be
Yeah,
done?
It's a great question. If the patient has a pulse and is still alive, we do the active external techniques primarily, and that can take maybe 12 to 15 hours until the temperature is normal, sometimes even a little longer. If the patient is in cardiac arrest, remember, they're not dead until they're warm and dead. We need to be aggressive with that. Unfortunately, I know my hospital has ECMO capabilities, but they often don't think it's indicated in these patients. So I have never successfully got a patient on ECMO. So I presume most places won't. ECMO rewarms them within an hour. All of our other methods, it sometimes can be 4, 6, 8 hours of ongoing CPR and warming measures, unfortunately, because it's a very labor-intensive, long process to be able to warm somebody who is severely hypothermic. So that is why it is much better to avoid a cardiac arrest, because once they arrest, it is a very long, labor-intensive process to try to get them rewarmed.
Mm-hmm. Thank you. And our hypothermic, in severe hypothermia, our patient has decreased level of consciousness. It is obligatory. It is obligatory indication to intubation or not?
Mm-hmm.
As for me, yes.
Yes.
How it's work?
That is a great question, because you could argue it either way. So if a patient is unresponsive with no reflexes, we usually say, yes, they have to be intubated. However, sometimes with these patients, if they have a pulse and with supplemental oxygen, their oxygen levels are normal, we sometimes say, maybe we won't intubate them yet, because if we put an endotracheal tube near that irritable myocardium, then if they go into ventricular fibrillation, we have a very big problem. Mm-hmm. So it's a little case dependent. You're not wrong either way. There's no great answer. If you do intubate the patient, we say do it very carefully. My residents, I say, try to use a video laryngoscope to avoid moving, and I don't let them position the patient. I say how they are is how you're going to do it. And it's a very slow, cautious advancement of the endotracheal tube. It's a very careful intubation. And I would only intubate someone who is fully unresponsive, because if they start coughing or gagging on the tube, that could also trigger the myocardium to go into ventricular fibrillation. So these patients are somewhat scary because they're so fragile.
How about laryngeal masks? Supraglottic airway devices, like gels, for example, like alternative method, maybe on first period.
Yes, and that would be a safer method, as they don't go as deep as an endotracheal tube. The problem sometimes with those is being able to get the mouth open enough, if they're frozen, to get it in there. It takes a little, at least the devices we have at my hospital, you have to get that mouth open farther to get the supraglottic device in than you would to get just like a camera in an endotracheal tube. But that would absolutely be an option on these patients.
Okay, thank you. And we had question about drugs, medicine, and during CPR and temperature lower than 30. Certainly, yes, of course, you answer on some part of this question. So, if we understood, if temperature of body care less than 13, we don't use drugs, and we wait elevation of the temperature, and only after that we can use epinephrine and amiodarone and so on. Yes, is it true?
Is it correct? I think the only medication I would consider in a temperature less than 30 might be glucose. If the serum glucose was very low, As we know, this has depleted their energy reserves. I would consider glucose, but no other medications would be indicated.
Next question. How many degrees per hour should core body temperature be increased? No, maybe some recommendation we have. Is there any limitation
There's
of this?
no limit. As fast as possible. That's harder than it sounds. So again, on ECMO, they can increase the temperature about 10 degrees an hour, so very rapidly. Hemodialysis, I think, is about 5 to 6 degrees Celsius in an hour. Everything else is going to be more like 1, 2, maybe 3 degrees an hour. It takes a long time, but as rapid as possible is the goal. You want to rewarm as quickly. There is no too fast as possible.
Thank you. And how about volume replacement? We use hot intravascular administration of the fluids. How much? Maybe how we should calculate what is maybe some algorithms and recommendations in this case. We think about it's our patient, hypothermic patient, it's like hypovolemic or not, how it's we should decide.
Sure. And I'm not sure if there's an exact guideline as to how much, as every patient is different. My usual is I start, for sepsis here, we always use 30 cc's per kilogram. So that's usually about where I start because I figure these patients are profoundly dehydrated. That should be enough, 30 cc's per kilogram. Most people, about 2 liters, to be able to increase their volume without inducing pulmonary edema and worsening a respiratory status. And then if possible, I know some of my colleagues are very proficient with ultrasound. They will look at the IVC to help determine further fluid resuscitation if there's capabilities for that. After the initial bolus, if we've already inserted a urinary catheter, we'll go by urine output, kind of like a burn. If they're making urine, we're probably doing okay. If we're not making any urine, we probably need a little more fluids.
So traditional approach to resuscitation therapy, yes, according to general diagnosis, yes, and comorbidities, so on. And monitoring, yes, of volume replacement. Yes, is it correct?
Yes, that is.
Okay, thank you. And question, in your experience, how much time do you spend on average warming of patient? It was you already answered that hypothermia, it could be and 5-6 degrees during hemodialysis and ECMO per hour, yes, and less specific methods, so it could be not less quick. Yeah.
Yes, it can take a long time. Whenever we have a hypothermic cardiac arrest that arrives, we all know we are going to be there for several hours. So,
do you have experience of using drainage, thoracic drainage, and lavage through thoracic drainage?
Yes, so my hospital, the way our health system works, I am allowed to place chest tubes myself. So I generally, because I know I probably cannot get ECMO, and they're often too unstable for dialysis. Nobody is going to do dialysis if they're actively in cardiac arrest. So my options generally are to place the chest tubes and do lavage. I would have to call a surgeon to do the peritoneal lavage, and that is very invasive. So I tend to not do peritoneal lavage. We will do external warming devices like a forced air heating, warm blankets. Don't forget around the head, like a little hat with warm blankets. We'll do warmed fluids. We'll do humidified warmed oxygen, as well as the chest tubes. And then one hospital I work at has the endovascular catheters that warm, and that works pretty well. It adds another about 1 to 2 degrees per hour when compared to the other methods. So works better than the usual active internal, not quite as good as dialysis or ECMO.
Thank you. Thank you, Jenny. Amazing lecture. Thank you.
This has been very fun to talk with you all.
Thank you. So, somebody have questions, colleagues? Maybe more. Oh, thank you, Jenny.
Yeah.
John?
Interesting question. I see. So our hospital system is set up. We have our main university hospital is our main trauma center, but then one of our sister hospitals a few blocks away handles most of our cardiac patients. So it's a mix. If our ambulance crews recognize the patient is hypothermic, they usually bring them to university hospitals. But many times they recognize the patient as ventricular fibrillation, and then they sometimes bring them to our other heart hospital because they think it's going to be a heart issue. And it's only once they've arrived we realize they're hypothermic. So most probably go to university, our main trauma hospital, where most of our residents are. But I've also had them at our heart hospital as well. So I see them at both. I see usually at least personally 3 or 4 of these each winter, and then our hospital system sees probably 5 to 10 each year.
Well, it certainly seems as though this is a rather specialized type of treatment that, well, let me rephrase that. This is a special, fairly uncommon type of a problem compared to, the typical pneumonia patient or urinary tract infection patient or something like that. So it makes sense to try to designate a specific hospital as the best hospital. I guess it's kind of like having a hospital that's very experienced in treating stroke patients, or something like that.
Yeah, the hardest part sometimes is recognizing our ambulance crews, our emergency services don't have capabilities for a core temperature. They only have tympanic temperatures or oral temperatures. So unfortunately, most of these patients aren't recognized as hypothermic or how hypothermic they are until they actually arrive at the hospital. So that makes it a little challenging to determine which hospital they should go to, and harder to say this is the best hospital because it's not something EMS necessarily always recognize in the field. It can be a little surprise when they arrive.
Yeah. Okay, I missed most of the lecture. Did you, obviously you got through all of your slides to the question slide. Did you go over case number 1?
We did not. We'll save that maybe if we do another cold lecture later. We'll save those cases. We went through the one of Anna, but I saved my cases just for time.
All right. And you said that one of your colleagues has expressed an interest in participating. Okay. Yeah. Maria, is there any specific emergency medicine topic that would be of interest to you?